Welcome to a conversation you won't hear in the OR lounge anymore. We're three orthopedic surgeons, Howard Lux, Jeffrey Berg, and Jonathan Hirsch. We've been in the game long enough to see surgical trends come and go, miracle technologies rise and fall, and the pendulum swing between innovation and overreach. We've each performed thousands of operations, but we've also learned that good medicine isn't just about the scalpel. It's about people, humanity, judgment, perspective, wisdom, and perhaps, best of all, knowing when not to operate. In this podcast, we're going to trade war stories, dissect lessons learned, and share the kind of unfiltered insights that only come from decades on the front lines of orthopedic surgery. And we're doing it in a way that matches our schedules and our personalities, unscripted, thoughtful, and to the point. Each episode is going to start with a single question I send to both Jeff and John. They are going to record their answers on their own time. I will add mine, and then we'll stitch it all together. What you get is a round table without the interruptions, a distilled conversation, where hopefully every word counts. I want to start our podcast with a question that frames the conversation we're going to have going forward. What do you believe is the single most important perspective, principle, or lesson you've learned in your career that younger surgeons or our patients need to hear right now? And why does that still matter today?
Howard, that's a good question. I guess I'd have to say that the lesson that I've learned after all these years is to move slowly. And not only does this have to do with orthopedics, but I sort of incorporate that in many of my activities at work and outside work as I age. In fact, I'm kind of surprised that in this fast-paced world, that humans didn't really evolve to move slower. When you move slower, there's less risk. You can see and identify subtleties that you can't see when you're racing along. How does this affect me in orthopedics? Well, I think I just slow down throughout the patient's journey. You know, when I meet the patient and interview them and we take a history, I sit down. I spend time taking a history. You, me, John, we learned long ago that a lot of times the answer, not only to the diagnosis, but also the treatment, is in the history. And although a lot of people have gotten away from it in these last years, I think that it's still very, very important to take a good history. And from that, I can often figure out what's going on and what's the best treatment. And to do that, to take a thorough history, you have to slow down. You have to listen. You have to ask probing questions. You have to be thoughtful. I'm also slow to get advanced imaging. You know, we've talked about it a million times, but MRIs have a lot of false positives, a lot of false negatives, essentially a lot of the noise. A lot of the information from it is very meaningless, confusing to the patient. It directs to unnecessary surgery and treatments, and problems. And so I think you got to be slow to get MRIs. Additionally, one of the things that I've learned over all these years, particularly in orthopedics, things take a long time to heal. And so you have to give them that time. You got to be slow to change your path. That may take a lot of convincing for the patient and even for yourself, but slow down, give it time to heal. And many things do. In fact, you know, and I know most things heal in orthopedics if we give it enough time. And so that also makes me very slow to indicate for surgery. You know, I realize as I get older and been at this longer, that most things heal and don't need surgery, and that surgery is not without risks. And even if the surgery goes great, there's a lot of cost to the patient. And I don't mean just financially, but there's cost of time and time away from their activities, work, there's pain and risk, and all these things that are difficult for the patient. And so, I think it's prudent to be slow to indicate surgery for most problems. And then when I do get to the OR, I still want to move slowly. Not so much slowly in the end case, but methodically and calmly. This keeps the staff calm. It sort of allows me to get into a meditative state of flow and where I'm focused and I can concentrate. And it keeps the chaos and sometimes a stressful situation down, which helps everything, including how we treat the patient. And then after surgery, I think, we all of us have appreciation for how long that post-operative recovery takes, and it's not a straight path. And I think you have to accept that, understand it, and realize it's going to be a slow recovery. And so I think over these years, I've just developed this perspective that you want to move slow, to go fast and go right. And I try to incorporate that in all aspects of orthopedics, and as I mentioned, even in my life.
Responds to your question about what I think has been most significant learning experience in my practice over the last 26 years is, for me, there's a lost art of physical examination and history taking, and imaging such as MRIs has really taken over. And that's really something that worries me. We've essentially fallen in love with MRIs. They're high tech, shiny. They give you beautiful pictures of everything inside your body. But the problem is they're getting overused. The first reflex when a patient walks into the office a lot or before they refer to me is, I need an MRI. Every single person that goes to the emergency room, on the discharge, they say, you need an MRI. Not, let's talk about when the pain started, what makes it better, what makes it worse. Let me examine you and see what's actually going on should be the answer for a doctor. I see so many second opinions where they, at the end of the visit, say, thank you so much. The first person that actually listened to me and even touched me. The MRI really should be a tool, not a crutch. It's like using a GPS for every trip that you ever take, even to your own kitchen from your bedroom. It's just overuse of technology. If we know how to listen to our patients' stories and actually put our hands on them, we often have the answer. The MRI can confirm or clarify the extent of injury, but it shouldn't be replacing our clinical reasoning and our skills in the clinic. And the biggest problem, and the kicker, is that MRIs can show abnormalities in people who have zero symptoms. Studies have shown, as we all know, that tons of us are walking around with disc herniations, rotator cuff tears, meniscus tears that we never even knew about. So if you jump straight to an MRI without correlating with the history and exam, you risk treating the pictures and not the patient. The science and art of clinical exam is lost. Everything is so fast-paced, and if you could throw up an image that shows a tear, you could schedule a surgery without ever entering the room of your patient. The tragedy really is that our younger generation is losing this skill. It's not necessarily their fault. They're surrounded in a hospital setting with beeping environments of electronics, MRIs, CAT scans for every patient that walks through the ER. But every time you look at that MRI, you have to pause and ask questions and do a physical exam. And usually the answer to what's wrong with our patients is right there in the room without ever looking at a computer screen. So the other thing is that when patients get their MRI report before seeing me, that word tear pops out on the screen or the piece of paper that they're holding, and they're freaked out. And I spend half my day talking people off a ledge about a tear in their hip or a tear in their shoulder and telling them there's nothing wrong with you and that has nothing to do with your pain. Even today, perfect example, patient had lower abdominal tenderness right over the edge of the superior pubic ramus. Clearly lower abdominal strain or something like a core muscle injury, but he was sent to me for a labral tear of his hip. They never examined his hip. There's nothing wrong with the guy's hip. You can't touch a labrum tear, so on and so forth. So, Howard and Jeff, I know you guys agree with me that we take our time with our patients, we listen, we touch them, and MRIs are confirmation tests or surgical planning tools. They're not the answer most of the time to what's wrong with our patients.
It's really not easy to think of one specific way to answer this, but one of the most overwhelming observations throughout my career has been the fact that most people just don't need an operation. And that could be for many reasons. Most people expect that their MRI is going to stay normal, even in their 50s, 60s, 70s, and beyond. As we all know, no one has a normal MRI. Everyone is going to have partial tears of this, perhaps a small rotator cuff tear, meniscus tear, and so on. Yet, these probably aren't the cause of pain. They are normal, age-appropriate findings. Yet people are told day in and day out, all across the globe, that they need operations for this. So I think we overtreat and we overdiagnose. And that's a large reason why the surgical burden is still so high in society, and why there are so many unnecessary surgeries that are taking place. One thing that adds to that, and I think a more important variable, is that most people, including probably a lot of surgeons, underestimate the amount of time it's going to take for someone to feel better. So, for example, an average age runner with knee pain, the pains on the inner side of their knee, it could be that the meniscus tear irritated or annoyed the tissues around it, and they're expecting to be able to run again in 2 weeks. Perhaps there's a little swelling too. They're expecting that swelling should be gone overnight. Well, all three of us know that pain and swelling can linger for a few months. And it's very hard to convince that runner that waiting is the best course of action. A lot of these runners and athletes of all types expect that the surgery will be the quick fix, and sadly find out the opposite on the other side of the surgical intervention, that their choice was a bad one. So I think we're operating on too many people. I think we're imaging too many people. Imaging is important, but it requires a long discussion about what the findings mean. I think we need to start that conversation before we order the MRI. It's not unusual for me, if I'm ordering an MRI of a knee or shoulder on someone over 40 or 50, that I'm going to tell them this is what I expect to find, but this is what we're looking for. And if we don't see what we're looking for, then we're in the clear and we're just going to wait this out and rehab the knee or shoulder. So again, it's hard to pick out one key observation, but I think this is a very strong one.